Hello, this is Bob Brown with part 4 of the Improving Nebraska Healthcare series. Today we'll talk about what other states are doing to lower their healthcare costs that we might be able to learn from. As mentioned previously, the United States has much higher healthcare costs than the rest of the developed world. We've been diverging since the 80s and just getting worse and worse, unfortunately, with no end in sight. Nebraska specifically tends to be on the high end of this. A lot of our analysis will show that Nebraska's healthcare costs are some of the highest in the country, often in the top 10, in this case, number 3 from the advisory board. Latest from the Kaiser Family Foundation just came out last week that healthcare costs, at least nationwide, rose 6% in 2025 and are looking to go up even more in 2026. This becomes an increasingly urgent problem as we are likely to see a lot of Medicaid shortfalls, and I think the legislative succession in the spring will have a lot to do with Medicaid costs, for example, which are part of the whole package, unfortunately. So I'll talk about what states are doing in 3 different buckets: sustainable growth rate targets, hospital pricing, and primary care spend rate. This is the areas where people are trying to focus on in other states. Sustainable growth rate targets, I won't spend a lot of time on this because unfortunately Nebraska has a hard time doing this because we don't have access to any of our own data. You would need an all-payer claims database, and Nebraska is not one of those states, but the states that do have them are diving into those claims to figure out where their costs are going and trying to make some interventions there. The list of the top includes all the states that have explicit targets, and then this lower paragraph here talks about states that are looking to develop them. I'll talk a little bit about Utah because it's yet another red state, maybe more culturally and politically closer to Nebraska. They are actually diving into their all-payer claims database and looking about maybe setting some price targets. But again, you just want to read this yourself. For us, it's just not relevant because we don't have access to our own data. We have to turn to other people's data, but then a lot of times that data is old and incomplete. Probably the best thing I can find is the Healthcare Cost Institute does put out some state fact sheets. In this case, this is 2021 data, so a bit dated. But in this case, our out-of-pocket cost in Nebraska is $7,694 per person, much higher than the rest of the United States at $6,467. And on top of that, our out-of-pocket healthcare costs are tough for consumers as well. So something we should look into, but not a lot we can really dive into because we don't have our own data to look into it in finer detail and set any of our targets, plus it's old data. So I'll spend more time about hospital pricing. And so this is an area where you could make a little bit more immediate impact, and the states that are focusing on this are doing it in very different ways, which is kind of interesting. So why hospital pricing? So if we look at Nebraska's cost sheet, for example, most of our prices are not going up for utilization. So quantity for the United States, there is some increasing quantity. In Nebraska, if anything, then this analysis went down. So it's not that we're using more healthcare, it's the cost of healthcare that's so much higher. Part of the problem is we have a lot of hospital market concentration of all the hospital mergers, and so that gives them a lot more leverage on prices, and so our prices in the hospital are much more expensive than prices in the office, for example. And so site of service can be an area where you can make quite a bit of difference. So a couple of interesting approaches. Maryland, I think, is kind of a unique way to look at things. What Maryland did years ago is legislatively they created an all-payer hospital payment system where essentially the hospitals, the insurance companies, public health people, other groups get together and they decide what is a fair price for the hospital to charge. And all insurers pay the same price. Medicare, Medicaid, Blue Cross, United, it's all the same price, so there's no cost shifting, which is a challenge in healthcare. And I'll show you some examples why that's complicated in the future. But they set it enough, though, the hospitals still make money, however, and it actually has worked out fairly well for Maryland. The analysis showed that they used to have hospital costs much higher than other states. Now they're actually lower than the national average while still maintaining profitable hospitals so they can stay open and provide services. So the cost shifting issue, here's an example. So Sage Transparency puts out some analysis of hospitals, and actually you can look up the Nebraska hospitals on this. I've covered up who it is, but you can go look through and find them yourself. What I'd like to point out here is the gray bar. That's how much the hospitals either make or lose on a particular population. You'll see that for Medicare, Medicare Advantage, and Medicaid, the hospitals lose a lot of money on every one of those patients. So in order to make up that loss, they have to charge commercial plans a lot more to make up those costs. The question, though, of course, is how much more? They do actually put in what the commercial break-even is. So if Medicare is at 100%, you have to charge more than Medicare. And in this case, basically 128% of Medicare is their break-even price. So they have to make up that 28% loss by charging other people's more. The question is how much more? Is 390% excessive or 172%, depending on what their fees are? So the real question is how much more? They do give some other analysis where they break down of our state versus national. And in Nebraska, our price difference is much bigger than most other states, actually. And so this is one of our challenges, and that's why people focus on hospital pricing. One interesting way, Oregon took a completely different approach. What Oregon said is essentially, well, they didn't really do too much about the private sector, but they said for state employee plans, instead of having a 390% charge, we're basically going to cap that at 200%. So the most you can charge a state employee for their hospitalizations is 200%, and if you're not going to be a network, then it's even lower at 185. And so that forced hospitals to lower prices, at least for the state employees. But according to this analysis from Milbank, saved the state of Oregon about $100 million over 27 months. So Nebraska could do something like that. An example that's a little nearer to me, I happen to be on the board of directors of Lincoln Public Schools, and this is public information. Our consent agenda every month, we write a check to Blue Cross Blue Shield. In this case, for last month, it was $7.5 million. And to do the math, we spend about $90 million in healthcare. So if we could cap the hospital prices for our employees when they land in the hospital at 200%, this would probably save us a couple $1 million a year. But again, that's something only the legislature could do. Indiana took a kind of an interesting approach last year. After an expose from the Guardian about how high some of the hospital prices were, they basically passed a law saying, look, if you're going to charge high prices that high, you're going to lose your nonprofit status, and that's a pretty significant penalty. We'll see if they actually follow through with that threat, but that actually could do something to lower some of those excess hospital prices, which sometimes can be 4, 5, 6, 800% of 8 times Medicare. So that is kind of an issue. California, yet another approach where actually it was a class action lawsuit. Sutter Health essentially bought up a lot of the facilities in the Bay Area and started using that market consolidation to jack up the prices, and they lost an antitrust suit brought in by some some employers that basically alleged excess or price gouging, and they won. So that just came out in Reuters here this year. So hospital pricing is one area you could go. The other area is primary care spend rate. It'd be a good place to start because maybe it's not as threatening and heavy-handed as the hospital price efforts. And so one way to explain this is what's wrong in healthcare. It's sort of like what you could or couldn't do in your car. So example, I could save money this year by not spending money on oil changes in my car. However, I may pay for it later in more expensive engine replacements. And most people will choose to pay for those oil changes up front so they don't have to deal with expensive engine replacements later on. This is part of the problem with American healthcare. We're not paying for the oil changes. Essentially, oil changes of healthcare is primary care and prevention, and because we under budget in primary care and prevention, we end up spending a lot more money in heart attacks, strokes, and cancers. Way to sort of demonstrate with this Nebraska data, one thing that we put out each year is the analysis of how all the Nebraska health physician networks performed on the Medicare Accountable Care Organization contracts. This breaks down each of the physician networks into the customer service they provide, the quality of care they provide, and then the cost, hospitalizations, and emergency room visits. And the way I explain to people is that the costs and emergency room hospitalizations, that's a trailing indicator due to a lot that can be either good or bad due to the investment up front. The investment up front, I would point out, is if you provide good access to care, and this is the accessibility, getting timely access to appointments for these systems, and they take good care of patients with doing things like care coordination and taking good care of them, then you'll get better blood pressure and diabetes control. And essentially everything green is above average compared to the rest of the accountable care organizations across the U.S., and you'll see lots of green here, especially these two. And these two have the lowest health care costs. They're 9 to 10% under budget and have the lowest hospitalizations and emergency room visits. So when you do a good job providing access to care to people and take care of their blood pressure and diabetes, it ends up causing lower costs overall, and that's why these two, I think, are performing better than the others. There's some other evidence. So, for example, this analysis of developed countries and what they spend on primary care and prevention, showing that anywhere from 8 to 19% is typical. Whereas if you look on this Milbank Fund for the United States, we spend about 4.7% on primary care and prevention. And so if you don't spend it up front, you're going to pay for it later. In Nebraska, this is actually an analysis Medicare did in 2021 of what the primary care spend rate is for Medicare fee-for-service, and you'll see Nebraska here at 4%, much lower than the developed world of 8 to 19%. Oregon's actually done some work on this where they actually have done some things to increase their primary care spend, followed it over time. And so here we have increased primary care spend and lower costs on things like emergency room visits and inpatient costs. And according to this analysis, which you can read if you'd like, done by the government of Oregon, is essentially that for every dollar they put into primary care, they were saving $12 in other services. So we could increase primary care spend as a way to lower long-term health care costs. Other states are going this same route. So here, for example, I've listed a couple examples. This is from the Primary Care Collaborative, this puts analysis of every state. And so Arkansas, Colorado, Oklahoma are developing explicit targets. Oklahoma, a few years ago, actually put into its Medicaid program that 11% would be spent on primary care as a response to higher Medicaid costs, as a way to lower their Medicaid costs long term. So Oklahoma could do this. We could do this. So should Nebraska do this? And I think this is one of our first areas we should focus on. We actually have a bill, LB 863, which was passed a couple of years ago, that created a primary care investment council to look into this. Unfortunately, it's sort of spinning its wheels because the governor has yet to appoint most of the council members, and it also has no resources at this point. We're helping them trying to provide some grant funding to see if we could get that kick-started. But one of the problems right now is, frankly, it just needs its members appointed. So the short answer is, we could do some things that other states are looking into. If you have more interest, I've put links to all these articles and references. If you want to do any more reading yourself, you're welcome to do so. Hopefully this is helpful and gives some policymakers and people in Nebraska some idea of what's going on and what could be done. And happy to answer questions if you would like. And the other links are on the YouTube site.